here's examples of home monitoring of different patient groups. Sorry, did it switch? Oh, you can still see it. Good. So we have a database of about 4,000 ICD pacemaker patients who are home monitored every day. You can have online heart monitoring if you feel that you have a heart rhythm that you're concerned about. You can have online heart monitoring. We have home monitoring of patients with diabetic foot ulcer. We are beginning to see a large increase in the use of home IV infusion of antibiotics across the medical disciplines, really moving thousands of patients who used to be hospitalized to treatment in their own home. And then we have one of our big successes is moving premature infants to treatment in the home with the help of the families. But I'll come back to that. So that's home monitoring. Here we have many departments who are really starting to use video consultation with different patient groups. That is happening in many areas and for many patient groups. Then we have tele-interpretation. So if you need interpretation, it's not a person, it's a person who show up on the screen. So you just order, say, on Thursday at 11 o'clock, I would like to have a Syrian interpreter, and then the interpreter is there and can work with you. Then we have our own little app. It's called My Hospital. And by now we have made more than 300 different apps in this generic system. And the number of active patient users are more than 25,000. And many of these apps include just pictures and information, but some of them also allows the possibility to having communication and contact with the department, so you can ask questions and send SMS. And for about 29 of them, we also have patient-reported outcomes. So we have questionnaires about the patient's state of health. And for example, for patients who had prostate surgery, they used to come, all of them, for consultation, outpatient consultation after 3, 6, and 12 months. And now we just send them a questionnaire. And based on that questionnaire, as an assessment is made of whether they need to come to the hospital. And for maybe 70% of the patient, we will just send them the answer, you're doing fine, we'll be in contact again in 3 months. So they don't need to travel 1 hour, 2 hours to the hospital. They can stay at home and they can be in contact, and they just fill out the questionnaire by use of this app that is completely free. So lots of initiative.
Kristian, sorry, I interrupt you. Is that okay?
Yeah.
That is not moving the slides?
Yeah, it's fine. I changed the slides. Sorry, can you see me?
We are still to the first slide, unless I have a problem.
Okay, I'll just start the sharing again. Okay.
You should now see the ability to
So home monitoring, video, tele-interpretation, and apps for patients, and apps including patient-reported outcomes. Can you see that now?
No, we are still in the first page. Yes, sustainable health does exist.
Oh, strange.
If you click on top right, you should find the ability to make full screen your presentation.
Yeah, I'll just...
Top right or bottom, sorry, bottom right or top left.
Okay. Let me try it again. Okay, and share screen. And this one. Okay, can you see it by now?
We are still there. When you choose to share the screen, you are asked to choose one of the different screens that you will see. Choose the top, sorry, the one on the right.
Yeah. Oh, let's see. Maybe I should wait and come back after the last presentation.
Yeah, okay, that's fine. That's absolutely fine. Eventually, you can send it to me and I will make the sharing, all right?
Yeah,
that's
I'll do
fantastic.
that.
So Edward or Ken, who wanted to introduce what you are working on and your view about e-health, while Kristian prepares for the next.
Laura, thank you very much. I'm going to be a coward, as I always am, and hand over to my better partner, Ken, who thrives in this wonderful environment, and we look forward to hopefully somebody might ask a question of me later, and I'll stumble on that. But for now, let's hear what Ken's got to say. Thank you, Ken.
Thank you, Ed, for delegating that to me, and thanks, Laura, and many thanks for inviting us to speak at this event. So everybody, my name is Ken Garner, and I'm the head of business development for Katlas Technology Limited. We're based in London, and we're the developers and vendors of the open source Katlas blockchain platform. So telehealth, telecare, and telemedicine systems, what they try to do is to deliver remote healthcare services to help to reduce admissions to accident emergency, hospital readmissions, community health visits, GP visits, manage scarce healthcare resources, and to prioritize the current, certainly in the UK, the current massive backlog of patient appointments. However, many of today's telehealth and telemedicine systems, they're analog, they're not digital, they're centralized, and fall short of providing the information security and privacy, the operational transparency, health records, immutability and traceability required in today's environment. Blockchain technology provides telehealth and telemedicine services by offering remote healthcare services that are tokenized, tamper-proof, transparent, traceable, and trustful, secure, scalable, shareable, sustainable, and with smart contracts, decentralized, data agnostic and dependable, carbon green, not carbon greedy, consent-driven, compliant, and coherent. In existing telemedicine systems, health organizations are usually unable to efficiently manage the silos of patient health records due to limited interoperability between the various platforms. Onboarding can be time-consuming and costly, and patient engagement can be really difficult to sustain. To overcome this issue, blockchain technology provides a single version of the truth for a patient like me, which the patient can see and begin to self-manage, which they can share with their carers, and which is also securely shareable across their entire remote multidisciplinary medical support team. The multidisciplinary team can bring together the experience of many medical professionals from various disciplines, including dentists, ophthalmologists, podiatrists, hematologists, clinical oncologists, pathologists, radiologists, clinical nurse specialists, and occupational therapists. So although blockchain technology is often called disruptive, you can actually achieve big changes from small change, linking prevention and improvement via behavioral change, with hospitals having to move their focus away from the pandemic to dealing with this huge backlog of urgent cases. Local joined-up systems must be able to deliver and deal with all modifiable risk factors, which determine much of our health inequalities and health outcomes. To deal with this, we need to address the social, cultural, and behavioral aspects of health and its determinants at a local, regional, and national level. So whether it's encouraging patients, encouraging smokers to quit, reducing alcohol intake, taking more exercise, or making healthier food choices, all can help in understanding and therefore influencing the behavioral changes that promote health, prevent disease, and reduce health inequalities. So a blockchain-based solution can join together local voluntary and community sectors with community-based healthcare, with co-designed and co-constructed, tokenized and incentivized public health initiatives. Blockchain enables the linking of empirical data from wearable or home-based monitoring devices, biomarker test kits, automated pill dispensers, and more anecdotal patient-reported outcomes and clinically validated quality of life questionnaires with validated attendance at, for example, community sports or leisure venues. Aggregating this data into a remote monitoring dashboard and remotely managing a cohort of patients in a proactive rather than a reactive environment allows healthcare providers to focus on the most urgent cases. Anonymizing this data also provides healthcare commissioners with a population-wide view, which possibly for the first time, can be visualized in near real time. So I hope this has proved to be interesting and helpful. If we've got any time left, either Ed or myself would be very happy to take questions. Thank you.
Thank you. Thank you very much. Yes, we will certainly have questions, but we take all questions at the end. Kristian, I have your presentation now. So if you want to, we can start sharing it.
Please.
Okay. Does everyone see the presentation?
Yeah, it looks really fine.
Okay,
so
very good. So just to tell me slide on, and I will change.
Yeah, next slide. And I can just start by saying that I'm the head of an innovation unit at the hospital, and we have about 10 senior researchers and about 25 PhD students. And it's their work I will give you a short introduction to. So as I mentioned, we have many technologies, and let's start with home monitoring. Next slide. Yeah, that's 5 examples of home monitoring. And next slide. Yeah, and 5 examples of video consultation. And next slide. Yeah, teleinterpretation. And next one. Yeah, the app we have made, and this is nurses and doctors in our clinical departments who have made these 300 different apps for 300 different patient groups. So instead of we do not give our many patients, we ask them if they have a smartphone, and we can see in the outpatient clinic or in the bed wards that we can see that they have a smartphone. We say, would you like to have an app about your treatment and how to make contact with the hospital? And they can download the app from the App Store. Okay, next slide. So the basis for this positive development, in my view, is to a high degree research, and research different from traditional clinical research, because traditional clinical research is an assessment, is a randomized controlled trial to see health impact of a technology. And we see this broader, and if you change to the next slide. Yeah, we see this as an innovation process that is starting with the clinical problem. For example, that COPD patients have many readmissions, and then we design a solution together with the patients and the relatives and the clinical experts. And then we do the assessment and assess the outcomes and the cost effectiveness. And then if we can see that the service do provide value for money, then we make the implementation and work with the staff and make sure that it's more than one nurse and one doctor who know the technology. And then we end up in routine care. Next slide. So the best example we have is the home monitoring of premature infants made by my colleagues, Christina Garner-Holm and Jane Clemensen. So it was a PhD study made by Christina, trying to see, can we move these patients from being at hospital for 4 to 6 weeks to being at home and being taken care of by the parents and have food, have the nutrition in a tube into the nose. So what Christina did, and if you go to the next slide, yeah, she started using this approach called participatory design, doing interviews, focus groups, and workshops with parents and with the staff to see what kind of training was needed for the parents, what kind of digital contact would they like to have. And this resulted in scientific publication, and then they were ready to do the next step. And if you take the next slide. yeah, then she did an health technology assessment. It was not a randomized controlled trial. It was an observational study following 96 families and infants, and compared that with a historic control group to see if there was improvement in clinical outcomes, in patient satisfaction, and in the economics. And we could see that the growth rate of these children was the same as when they were in the hospital, but the families were very glad not to have to stay in the hospital and to separate the father and the mom, but actually they could stay all at home together with other children and help the baby. And it was also very cost effective because we saved lots of money on not having the families in the hospital. And if you go to the next slide, they were ready for the implementation. So the clinical department said, well, we need to give all of the premature infants this service. So they made training of the staff and gave them peer support and gave them a good understanding of the benefits for the babies and the families. And then this was actually helping now for all of the premature infants in the hospital and really making lots of space for other children in the beds in the hospital. Okay, next slide. So eHealth is really sustainable, and it is a central part of our future healthcare system. And I really do think that the use of scientific studies is what we need to make sure that these new services are based on the needs and the demands from the patients, and that they are cost effective and they do give value. And finally, we need more than randomized controlled trials because the value, and we need more than just studies of the clinical outcomes, because the value of these services can take many forms, and often it's not clinical, it's about patient empowerment and patient satisfaction and stuff like that. Thank you very much.
Thank you very much to both of you, Ken and Kristian. One question pops me in mind. Yes, eHealth seems to democratize the services. However, you need first to have the tools, and even before you need to have the connection. So finally, is it going to enlarge, to broaden the divide?
Is it going to broaden the divide?
So making even deeper the difference between those who can access eHealth services and those who cannot, due to technical problems.
Yeah, well, in the beginning, the first studies we made, we tried to make telemedicine that it should be something that all patients should use, but that was extremely costly. And now we are using software solutions where we're using the fact that 70 or 80% of our patients do have a smartphone or a computer and internet connection. So they don't need additional equipment they can use. The principle is called bring your own device. So we're using the patient's own hardware and own devices, and then we just send them a link and they can click on the link, and then they can have the app, or they can have video consultation or home monitoring. So you are right, it's not all patients who would like this. And we have seen in Denmark that about 10% of the population do not like to have digital contact with the government or the municipalities. So they have asked to be free of digital communication. So they get the old paper letters, but 90% of the citizens are okay, and they are used to be in digital contact with the municipality and with the state and with the government. So we're trying to say, let's offer this service to all of the patients who would like to have digital communication, because it's not for all. And in some cases, I mean, you can be you can have a cognitive impact of your disease. So there can be many situations, or you can be, maybe you just never tried using a smartphone and you don't really trust it. well, then you should keep on using the hospitals in the old way, but maybe for 60 or 70% of the patients, this is a good service, and it still can provide value for many patients. So we don't have to sort of push it to the last part of the patients who really don't like it. They can still use hospital in the old way, but maybe 60-70% of the patients can use the digital communication with the hospital and have benefits from that.
Let me understand. We are talking about patients who don't like the eventual shareability of their data with the government or with any other institution related. So it's a matter of willingness, not of ability. So what I was referring to was much more about what if an individual doesn't have the education for using these services or the tools or the connection. So you said the 90% do have a mobile. I certainly believe it, because the north of Europe is renowned to be particularly advanced. And I'm surprised that in the northern, some are skeptic about governmental systems, because it seems that you have a very good well-distributed, let's say, public service. However, probably the focus, I don't know if Denmark has a specific case, but there are considerable part of economies that cannot afford these systems. And there are huge areas of the world that will never, or have huge difficulties in connecting, for example. So what do you see e-health coming? Will it remain something for advanced economies where connection exists, culture exists, and there is a stronger government, or?
Yeah, well, in my view, we have started this digitalization of healthcare, and the pandemic has really sort of increased the demand and the use of digital services quite a lot, and this will go on, in my view, and we have the hope that maybe 30% of our outpatient visits can be removed from the hospital to digital contact with the patients. And at our little hospital, we have 1 million outpatient visits a year. So many thousands of visits every day, all year round. And our hope is to remove 30% of these visits and make them digital. For many
I perfectly see the benefit for hospitals, yeah, and also for people, but yeah, I'm trying to understand if e-health is something of which hospitals will benefit or people will benefit.
Well, in the good cases, it's a win-win situation, but in many cases it's actually the patients who win. It's the patient with chronic disease, with COPD, with diabetes, with heart disease, with arthritis, who don't need to travel and eat. Denmark is a very small country, but still, patients with a severe chronic disease, it's very hard for them to spend 1 hour of travel and then have to wait in the hospital and then seeing a doctor for 5 minutes and then again wait for 1 hour and then 1 hour transportation. Some of these patients, that is sort of the most hard experience they have for months. So even though it's just a 5-minute visit at the hospital, it can be very hard on a patient with chronic disease, and doing that for the rest of your life can be very hard and have a large impact on your quality of life. So for many of these services, it's not about making the hospital more effective. It's actually about making healthcare more beneficial and making it easier to live a life with chronic disease.
What do you think, Edward, Ken? What is your perspective?
May I ask a question of Kristian? Kristian, for patients that don't have Danish as their first language, have you had to localize or translate your app into other languages, and how does that affect the data that you're getting back?
Yeah, well, you're putting your finger on a crucial a problem that we have, and we are trying to improve on that area, but so far you're right that most of the digital services are only for patients who do speak Danish.
Yes.
But we have this very well functioning system with having digital translation. So if you have an outpatient visit and you need interpretation, you can just have a talk between three persons, the doctor and the patient and the interpreter, and that works very nicely.
Good. I have another question, if I may, for Kristian. The UK is very, very, very active now in the development of biomarker test kits. Because of the way that lateral flow tests have kind of softened up the market, made it easier for people to accept home testing for biomarkers. It's a huge amount of money. And we're very active in that area. We're very interested in it. A biomarker test kits and the data that can be obtained from biomarker test kits for now a very wide range of diseases. Are you going to incorporate those into your technology? Yeah,
lots of our home monitoring services include measurement of lung function and blood oxygenation and blood pressure and even weight and also physical activity. So we are, but it's still sort of starting. It's not really big scale by now, but it's growing, and we have seen that it can be done. And in many of the hospitals in Denmark, they have apps similar to our apps, and they are able to get in Bluetooth contact with the devices and thereby bring the data into the hospital. So it's still small scale, but it's growing, and I agree there's lots of potential there. But there's also lots of potential in these patient-reported outcomes, actually.
Yeah. Absolutely.
And that is, I think that's really going to grow a lot. And I was having a very good meeting with our Department of Gynecology and Obstetrics, and one of the doctors said, well, in a typical day, I will have 14 patients in the outpatient clinic, and maybe somewhere between 2 and 4 of the patients don't actually need to see me. They are okay. So if I had very basic information, maybe if they answered 5 or 10 questions, then they don't need to come.
Yeah.
So I do think, this is actually related to our financing system of the hospital, because we used to have activity-based financing. So the higher the number of outpatient visits, the higher the budget. So we had an incentive for many years to increase the activity, and so a visit was always a good thing because we made money on it. So but now that has, I'm very glad to say, that stopped, I think 3 years ago. So now we have a fixed capitation payment system. So we know from January 1st, we know exactly how much money we will get, and we are not paid additional for additional activity. So by now we are seeing a growing interest in trying to reduce the number of outpatient visits and get rid of those who actually don't have any clinical value.
Yeah. Can I move the conversation to the core of this session, which is data? How are data managed? And well, we are talking about very sensitive data that may come from diagnosis or activities that happen between the doctor and the patient. And that you are talking about a kind of feature that is very, very centralized. How do you manage the risk that is associated? Do you care about that? Do people care about data or not so much? What do you think?
Yeah, well, it's if I may start, it's a big concern, and the politicians in Denmark have made the laws on data safety, and especially data related to health, very strict. And I have been working at the hospital for I think about 19 years by now, and we did lots of stuff back then 19 years ago that is absolutely impossible by now. So on the one hand, we can see more and more possibilities for using data to make the best possible treatment of the patients and do great studies. But on the other hand, the limitations, it's getting stricter and stricter. And it's very difficult to get permission to use patient data unless you have asked the patient up front, can I use the data? To go back and look at old data of patients is very, very difficult. So there's lots of concern and lots of safety issues every time we are using patient data.
How did you manage the consent of the patients, if I can ask?
Yeah, well,
how it happens?
Yeah, well, if we're going to use the data for any kind of, for example, for doing statistical analysis of patient-reported outcomes to find relations that we can use, then we need to apply for the scientific board, and actually we do need to ask the patient up front. And if we would like to use old data, then we have to ask the scientific ethical committee and also ask the medical authorities if we can do that. So it's
technically speaking, how do you manage it with the app, with the mobile applications? Because I mean, the risk is there. Okay, I get that you have the consent. All right, there are a lot of regulations, right? But the problem, despite the many regulations, there are risks that are associated with the tools, with the technicalities.
But every time we have a device that is collecting data, an assessment of the data safety and also whether it complies with the data regulation, that kind of assessment is always made. So you cannot just start using a device for data collection. You always need to have an assessment being made upfront of the device and of the data safety.
Yeah, for sure. But the problem is that many breaches happens, although we have a lot of regulation in place. I'm not talking about Denmark in specific, of course. I don't know your statistics, but I certainly know those of the UK, and which is considered, yes, Edward, I'm coming, which are considered to be safe, and finally they are not so much. So I'm just trying to understand that I don't doubt that there is the willingness to preserve users to have any kind of risk from data breaches, but data breaches happens every day. And guess what? The healthcare space is one of the most targeted one from hackers. Edward, do you want to say something? Well, Kristian, I didn't want to cut you, but I come back to you.
Yeah, I think it's on the theme of where the data is captured into, stored, and how it is shared. And I wanted to point to the fact that Katlas has spent since 2019 building a decentralized patient wallet. And the benefits of a decentralized patient wallet is that the patient has always got a summary record of their own data from whatever source they choose to capture it from. As Ken was saying earlier, whether that's a dentist, optician, or cardiovascular device. If they're able to, in a decentralized system, they're able to be prescribed questionnaires, which they can then populate on their mobile or upload. And this allows, with the benefit of a standardization node, if you will, to make sure the system is operated properly. It allows the patient to build a summary record, which they can open. They can provide an open API to that wallet to each and every individual they choose to. Now, and this enables GPs to access it. It enables the community care to access it. It enables them to pass responsibility to a carer so that they can manage that data for them. And it seems to me it solves the biggest problem we have, is that as a customer of any universe, and particularly a patient, I actually don't know the data myself. I don't know what data is held by who, where. I know that I've got some data for GP. I've never probably thought about what my dentist is holding, or even the chap that fits my shoes. You know, I really don't have a picture of myself. And I think modern technology is enabling that picture of yourself to actually happen. Digital, you know, open APIs are making that a possibility. But the great differentiator is the blockchain itself, not a blockchain that stores data, but a blockchain that timestamps a location, an activity by a person. And this, you know, that unique timestamp provides a level of verification and authority to that data that people can rely on. And so we have, I think people have dreamt of this solution. There's now being designed, the technology is available to make this a reality. But the truth is, in healthcare, from our experience, is there's quite a big reticence to I've seen a lot of talk, I've seen an awful lot of things written about empowering patients. But the actual talk and the actions, there's a long, big gap, because the solutions we're seeing are largely mean that I've got to share data, not really anonymously. The state takes it, or a corporation takes it. I do it because I need the care. I don't do it because I want to share my data. I may not be against sharing my data, but I don't really have a choice. And so we talk about giving empowerment to the individual, but I think the opportunity is there to provide it. But in my opinion, at this juncture, there seems a reticence to give people that level of control over their own data.
Kristian, did you want to add anything?
Well, just that I think in many countries it's a big concern for the hospital managers. They do not like to be in front of the news saying that now this hospital has given away data from their new app or from their new IT system. They are very concerned about this, and they are really scared, and therefore we have a strong sort of organization who really do look after that data is not floating around, it is not available. So it is data safety is a big concern for the politicians, and I mean the politicians are the ones who sort of are in the end regulating the public hospitals we have. So the hospital managers are very concerned about data safety. So I don't think we have. Maybe this varies from country to country, but still I think that the safety of the hospital data is quite high, especially in the Nordic countries, and I suppose in many other countries. But there might be some places where you have troubles.
Yeah.
Well, in the UK we had the troubles, right? let me understand that. Do we see a future where the individual will finally manage this famous wallet of data, or is it just a dream for me, Edward, and a few others?
Who's that question for, Laura?
For whoever has an idea to share.
Well, I think we need to understand whether there's a willingness, or whether we think that's the preferred option first, and then whether there's obstacles. If it's the preferred option, and we all agree that it's a potential utopia, but if we don't agree, that's a different answer. One thing we are seeing anecdotally from customers, and this is I'm not a specialist in regulation, but anecdotally I'm hearing that private hospitals in Germany, private patients or private hospitals in Germany are very now very nervous. In fact, the clinics themselves are very nervous because they're now obliged to provide private clinic data to the government because the government wants a broader picture. And the patients don't want the private clinics to provide that data to the government. So here we have an opportunity for the private clinics to hand the responsibility of storage to the patient wallet. And the patient then has the obligation to share it with the government if they so choose. Now, so where I see the change, to answer your question, do I think it's going to happen? Yes, but in the private sector first.
But I want to understand if eventually the public sector was willing to open to a more distributed system, would that be technically feasible? Because organizations in the health sector are typically very, very centralized. So yes, of course, you can rebuild everything, but it would be quite utopian, this idea. So what could be, how would that work with the present situation, an open context where the individual can travel from one service to the other with their wallet and with their data, given that today is definitely not like that? Well, how would you put together the public and the private sector to the benefit of the individual, with the individual as a centric entity with their wallet and their portable data?
Yeah, that's a good question, Laura, and I'm not the one to answer it, since the public healthcare is 99% of healthcare in Denmark. But there's a lot of talk about sharing data between primary care and secondary care, and that is still a challenge because the care that is going on in the municipalities. And so that is sort of one sector, and the other sector is the care going on in the hospitals, and they are still not sort of sufficiently sharing data. So I think that we're going to have a health reform in a short while. The government has announced that, and the health reform will especially focus on the need for more integration of data across sectors.
So that's more centralization, but from more sectors. Is that a big data solution, or is that a decentralized solution?
No, we have had for the last 20 years, we have had centralization of healthcare, but now it's going the other way around, and we are going to have more decentralization because we see that too many people are going directly to the hospital, and we need sort of the less sick patients to stay in the municipalities in maybe smaller local hospitals with a few beds, and we have seen that in Norway, and I think we may be going in the same direction in Denmark.
One quick question, actually. Sorry, Kristian, and sorry, Laura. Have you seen with COVID? I'm speaking personally, anecdotally, but have you seen with COVID because the time it takes to get an appointment, because the lack of potential face-to-face, that people are more likely to go private on a subscription type model, or might be more inclined to buy gadgets and fill in questionnaires remotely at home, so that they can at least get a picture of their health immediately, rather than waiting for the public sector. So are you actually seeing a growth of subscription type services in the private sector? It's my
good question. We are, for the last 2 or 3 months, we have seen lots of commercials from private companies where you can buy access to a general practitioner on video, and that has not happened before as I remember. So I do think that the private sector see some potential in the healthcare crisis that we have in countries like Denmark right now, because we have lots of pressure on the hospital and we are lacking staff. It's really hard to find a nurse or a doctor for the hospital. So the hospitals are really under lots of pressure and have difficult to keep the production running. So I do think the private sector will see the possibilities, and that people will buy some kind of private insurance still at the moment, the private sector is very, very small. The private healthcare sector is very small in Denmark, but I would guess that it is increasing.
Okay.
What I'm wondering is that we talk a lot about healthcare data shared across different organizations in the healthcare space, but still we are not talking about sharing data with the individual who owns those data. Let's make the case of COVID. It was a mess deciding how to manage these certificates, and I tell you, I'm very surprised that in the UK at the moment, I'm taking a test at home and I get a certificate. I could have given somebody else to make my test, and there is no solution for making sure that I'm effectively the owner of that test, and I do have a certificate. And why? Because basically I'm not allowed as an individual to enter in the database of the healthcare system. But if there was some kind of ability to make sure that a certificate is unique and that is shareable, well, probably we would have not spent 6 months to decide how the COVID pass could be done. So I'm wondering if there is some kind of preconception on the part of the healthcare system, wherever it is, against some form of distributed system. So they say no, basically, because they don't like it, or because they don't know it. What do you think? Ken, Edward, I
can answer it. You've heard enough of me. I think Ken's got some good insights on this type of thing. So I'm going to pass that. I'm going to say rugby union ball, but it could be a rugby league ball from the man from Wigan.
Laura, I think I understand your question. It's very difficult in the health field to get that kind of idea across. Healthcare is only one of the areas that we're working in. We're active in quite a wide range of different use cases: agricultural technology, mining, a whole range of different things. But the attitude within healthcare is they're very slow to adopt new technology, but you can't self-isolate from technology in the current environment. So I think that what you're suggesting is going to have to come, but I don't have any unique insight into when or what the form will be.
So e-health, Kristian, is will be a set of mobile application that somehow are governed by a central organization that is certainly facilitated, and of course gives also facilitated services to their beneficiaries. Is that the model, the design that you see?
Well, each country have to make their own solution to how to provide e-health, and there are thousands and thousands of possible e-health technologies. So there are so many possibilities and so many ways to do it, and we in a sort of public financed free healthcare system has found an easy way to do it. It is not sort of very high level technical, but it's kind of cheap, low cost services, but we were providing it for many patients, even within our little hospital. So I do think there are lots of possibilities to do this in a way that is not costly and that is very beneficial for
Thank you.
many patients.
We have another few minutes. I'd like just to have a couple of words about the future of AI and the machine learning for healthcare. How do you see it beneficial? Where can it be used, if anywhere? You or Ken or Edward or whoever wanted to say their word, please.
Well, I'd like to just mention that we're using that type of technology for predicting cardiovascular risk in people who wouldn't otherwise know they've got a problem. So that's our R&D project. It was our proof of concept, and we've done this with a private clinic in Barcelona, a specialist in cardiovascular recognition and treatment. And how this works is that they call it a health coach system, and their vision for health is for when there's a problem, for almost like a sort of scooter care, if you will, where people will respond by a health coach who's not necessarily a skilled cardiovascular specialist, but has been trained as an operative to fit equipment, to onboard a patient wallet, to make sure that the readings are taken correctly in the first instance, can do that in their own home. Now, where this and so what they want to be able to do, therefore, is to get an initial picture of a patient in their own home, and for a remote specialist to act a little bit more like air traffic control, who is able to have these readings shared with computer algorithms, AI ML. It's been trained on their population of cardiovascular patients, and they're able then to use computers to give an assisted diagnostic of the patient. And if that throws, of which the remote cardiologist can take a broader picture together with video conference to see if that patient, what their next steps should be. And once this has been done, with the benefit of medical devices and with the benefit of questionnaires, whether that's daily or weekly or monthly or whatever, they're able to build in tolerances, able to use computers, if you like, to classify that patient's level of urgency should anything significantly change. And so their vision is for them to be able to monitor and manage a lot more patients, particularly those who are more vulnerable to cardiovascular, than they currently do. There's no real picture out there of who's vulnerable and when they might next need treatment. And so their vision is to give them questionnaires, devices, and use AI ML engines, which they train themselves to deliver at least an assisted diagnosis.
Okay. Kristian, what happens in the north?
Well, so far AI is mostly being used in analysis of pictures from medical examinations and in radiology, and so it's kind of funny actually, because there's a lot of sort of political focus on AI, and if you would like to have funding for research, you need to use the word AI. But and that is great, and there's lots of potential, but the real change that is going on right now is the types of telemedicine that I mentioned briefly, because that's where we do see the revolution at the moment. But hopefully in 3 or 5 years we will see an increase in the use of AI, but we are still lacking to see the demonstration of the clinical and economic values. There are very, very few sort of randomized controlled trials or similar studies of the value of AI. It is claims and expectations, and that is great, and we need to start from that, but there's still a long way to go. And my guess would be that the technology AI will develop in the same way as most other health technologies, in accordance with the hype cycle. So we will have lots of focus and lots of expectations, and then unfortunately we will see that it cannot solve all the problems we are hoping for, and then in the end we will find you will find that it actually does work in some cases. And we're still in the beginning of that curve, I think.
The famous Garner disillusionment. Yeah, I see what you mean, for sure. It seems that is something associated with any technology in any case.
Yeah.
Well, we have another 3 minutes. Would you like, guys, to give a quick overview of what are the skills needed to be part of the e-health space and the telemedicine, which are the skills very much needed for the future in this context?
I'd certainly like to see digital health become part of nurse training and midwife training and doctor training. I think that a lot of the training that they do is based on technology that is becoming out of date. I don't know how easy or how difficult it would be to change the mindset of the parts of our health systems that train nurses and doctors and the specialists, but I would certainly like to see more and more emphasis on digital health technology within the training environment.
Would you see virtual reality and augmented reality in or the metaverse in training?
I think for surgeons, virtual reality and augmented reality is I think it's very close actually. But whether a nurse on a ward would ever don a headset and go through virtual reality, I don't know. But the bigger picture is they have to have training in digital health. And I don't necessarily think it's actually happening at the moment.
Kristian?
Yeah, I completely agree with Ken. We have started to have this as a small part of the curriculum for both those who study medicine and also for the nurses, but it's still sort of just started, and I hope that we will see an increase, because when I teach our medical doctors, well, it's not sort of it's not in their heart. They will do it and they will show up, half of them, and they will do the exams, but it's not really sort of what they're most interested in, because I do think they feel like they want to be medical doctors and want to be in contact with patients, and I'm kind of moving the patients away from them. So it's really not easy, and we need to have to put more effort into it, I think.
A cultural aspect again.
Kristian, I've got one comment which I'm welcome to have you throw straight back at me. But my recent visit to a GP, long overdue, I might tell you, and the session lasted a bit longer than it possibly should have done if I kept myself in better shape. But what I can tell you, there was an awful lot of Googling going on by the GP, who I massively respected, and I was given great care and concern, and the face-to-face was wonderful. But Googling was what was going on when it came to, what might be the problem here and what could otherwise be problems here. Because I think we've lived in a bit of a world in the past where people would rather assume that GPs know all the answers. And I suspect, and why people like AI, is it may not, we don't know whether we got the right answer or not. Of course, we want the right answer, that's what we see. But so many different more factors can be considered, contextual factors, broader factors, which a human brain is unable to manage at quite the speed and complexity. And my suspicion is the GP would love to carry on doing what they do, which is face-to-face and all the rest of it, but would like to be better informed. So I'm thinking there is a win-win here.
Yeah, yeah, I think, medical GPs are quite different. And in Denmark, as the pandemic hit us, we saw the large increase. Now we went from a few, maybe 20 GPs offering video to 1,000 doctors, GPs offering video consultation in March 2020. But now we are, well, we're not where we started, but we are not much different from where we started. And it's only a few of the GPs, or it's only a small percentage of the GPs who really continue using video consultation. And most of them have actually stopped or almost stopped using video consultation. So it's actually not, by now it's sort of up to the belief and gut feeling of the GP whether he will offer video consultation or not. So I do think they vary in the same way as we do, as the average citizen do. And some of them think it's fun, and others are maybe more old-fashioned.
Okay, last question, answering to the initial question, is e-health possible in a sustainable way? Yes, no, and how? But very, very briefly.
Yes, it is possible, but it depends, as we talked about, on the culture of the doctors and the perception of the citizens, and then you need to have the right financing system of your healthcare, because if your healthcare system is based on payments that are based on physical contacts, then it will never happen. So you need to have the right financing system.
Thank you. Ken, Edward, what do you say?
It's possible, it's doable, it's essential.
Yeah.
Good, fantastic. Edward, that's fine. Well, we close it here. Thank you very much for being with us, and see you again next week. TiiQuTalks on TiiQu.com. Thank you very much.
Laura, thank you very much indeed. Lovely to meet you.
Love to meet you.